Hello, and welcome to a Swift View on Health. My name is Scott Schoenvogel, and today I wanted to talk to you about a new Medicare mandate that was going to require, starting in 2028, bundled payments for joint replacement. So, what that means is that if you go in for a joint replacement, Medicare is going to pay a fixed amount, and that amount will cover the joint replacement plus any care you may need 90 days after that procedure. So this is paying a fixed amount for an episode of care. And why this is so important is that there's a lot of cost right now associated with readmissions as well as ongoing care around things like surgeries, joint replacements, etc. And this is a model by Medicare, which is changing the reimbursement structure. So instead of every time someone comes into the hospital, regardless of whether it's for the initial procedure or some kind of follow-up service getting paid, they're just going to get paid one fixed amount. And now the provider itself has to manage the risk, has to manage the care for making sure there is a successful outcome. Um, so within that, hospitals now are having to think very differently in order to prepare for this new reimbursement model on how they manage hip, knee, and ankle replacements. So once those procedures are accepted, they know they'll be on the hook for any cost or services related to that procedure for a 90-day period. If the cost is in excess of what they pay, then the hospital will be eating that difference. Obviously, if the cost is less, the hospital will be making margin. And so the goal of this program is really to create incentives and motivations for providers, in particular the hospitals, to be able to deliver care models where they can basically take on that risk and continue to improve care and care efficiency so that those outcomes once again become more cost effective and those services become more cost effective over the time, which is really the right incentive that we want to see for healthcare. We want our healthcare to become more effective, more efficient, and cost less over time. I think the challenge with this model, if you were a hospital, is that there is a mandate for participation for the most part. So if you want Medicare reimbursement, you will basically have to take on this risk. And just being able to manage that risk, I think they're estimating that organizationally, procedurally, structurally, there might be costs in excess of $1 million just to get ready for it. And, there's concerns that because these services are exclusive to just hospitals and inpatient care, that there might be quite a bit of just procedural management inside of care management that's required for hospitals going forward, meaning that if a service can be provided in an ASC or an ambulatory surgical center, perhaps the hospital chooses to perform that surgery in that center versus the inpatient hospital setting because it won't have the same requirements for bundled payments. The ASC could continue to bill for additional follow-on services where an inpatient visit at the hospital could not. Now, in some cases, that could be good. Oftentimes, ASCs are lower cost than the hospital inpatient setting, so moving a procedure there might be more cost efficient, but it may not be clinically appropriate or clinically safe. And so something that we have to sort through. Obviously, this is a big deal because once Medicare effectively establishes a new reimbursement policy, that oftentimes sets the standard that the rest of the industry follows. So it's creating a new level of financial accountability and financial risk for hospitals and those healthcare systems in the market today. And as I mentioned, what happens in Medicare generally starts to follow into commercial plans and reimbursements as well. So when Medicare created fee-for-service, that was adopted by commercial plans. A lot of the same billing standards and structures are used by both. So this is likely going to matriculate into the commercial payer world as well, which is already a direction that world is going or is wanting to go. So a lot of the Center of Excellence contracting work exactly in this manner today. Providers are stepping up, they're taking a bundled payment, and they're taking risks for the outcome of that surgery or procedure in return for, the steerage and guidance of patients to that provider. If they're doing direct contracting or even just gaining access to certain network strategies, already there may be these requirements in place. And employers really want those types of case rate protections because one of the things that makes employer healthcare, healthcare and insurance so expensive. So for these commercial plans is that there are a number of provider contracts in the market today that are somewhat open-ended. So that means that the more care you get, the longer you stay in the hospital, the more things cost. And when those costs, run into the hundreds of thousands or even millions of dollars, that creates risks for commercial health plans now that they really don't have a great way to manage. And the industry that's trying to do that right now is really struggling to do so. So I think once Medicare establishes, this protocol, you're going to see significant pressure from commercial health plans to adopt it as well. So this, in my opinion, is a major signal. We're just at the beginning, but a major signal that there's going to be a new kind of philosophy around reimbursement related to hospitals. A philosophy where hospitals will be taking on a certain amount of risk for outcomes, particularly from a financial standpoint. And as such, this is going to be important for hospitals to start to prepare for now. So, if you're covering post-acute care 90 days down, it's going to be really important to make sure that your nursing facilities, your physical therapy, your home health partnerships, all of those are highly coordinated. So you're going to need to invest in more care coordination to make that so. And you want to make sure that you're ahead of these relationships early, as we talked about with centers of excellence, direct contracts, but really engaging those commercial payers around programs and protocols that not only work for them, but work for you as a healthcare system as well. Once again, major shift in industry reimbursement protocols is potentially ahead of us, so something that we all need to be aware of and focus on. As always, thank you for listening. We appreciate it, and stay swift.